Dossal, and thrilled to see you all here during this auspicious week at the UN for the UN General Assembly, and for this timely and important conversation around AI and global health. So first, a huge thank you to the Public Foundation and the Health Equity Forum for what they've put together, how they've pulled everyone together, and against all odds, especially a week like this, we're all beneficiaries of their incredible work. Now, why this conversation? You've been hearing it. I think we all hear about AI, use AI, but why this conversation? Why now? Artificial intelligence holds an unprecedented potential to close health equity gaps, if applied thoughtfully and inclusively. That's the big if. So AI could be the ultimate equalizer, or it could be the ultimate divider. The point here, and the topic for today, is to discuss how do we ensure it's the former. By way of context, Henry Schein is a global provider of healthcare products and solutions. We have about 26,000 employees across the company serving 1 million customers. So in short, anything that you go to a dentist office or a doctor's office, anything that they have in there, chances are we probably have some sort of role behind the scenes. Our involvement in AI, we've been basically experimenting to date, looking at internal opportunities, we have a partnership with Henry Schein 1, which is technology for practices, but we've been in the early stages. I think really more the opportunity for me is to listen and learn to this esteemed panel. So without further ado, I'll mention that I focus on helping to scale new ventures within the company and some of our public-private partnerships, something that's really important to Henry Schein as a company, to, as we say, make health happen. But now onto the exciting stuff. So let me introduce our panel, who each bring a unique and powerful perspective to this conversation. Dr. Eva-Marie Muller-Stuler is a global leader in AI strategy and ethics, an important component of this conversation. With experience spanning government, business, and research, she's helped shape AI frameworks that prioritize responsibility and inclusion, ensuring that this technology serves humanity rather than the other way around. Mr. John Martino is the founder and CEO of a very innovative company called Synseer. And he's an innovator who knows firsthand the challenges of taking real-world pilots and scaling them into larger impact. So he represents the entrepreneurial spirit behind driving transformation. And last but not least, Dr. Aerts leads the Novartis Foundation. And her career has been dedicated to addressing global health inequities. And it's been focused on how data, predictive analytics, and partnerships can be harnessed to transform population health. Outcomes from cardiovascular disease to citywide health initiatives. So we're incredibly fortunate to have you all here. Let me first start off. You've seen their impressive bios, but rather than me reciting them, and to add a little bit more context to what I shared, I'd love for you to share a little bit of background on yourself, do a 1-minute lightning round, and then why you're excited about AI first.
I think why I'm excited about AI, I can go on for hours and hours. I think with AI we have a tool that we can really, it's a double-sided sword, and we have a tool that can really change the world we're living in. We are in a transition period actually now with all the chaos that we're seeing around us, where we are transitioning from the world before AI to the world after AI, and really defining that the future is our moment now. And so we have to make sure that we use the AI in the right way, and that we manage the risk, and that we actually are using it to build a future that we want to live in, that is equitable and fair for everyone. We give opportunities for people that we never included before. And my background is I was a CTO for AI for IBM in Middle East and Africa a while ago. And in that you really saw targeted solution that you can bring into the area we had COVID at my time at IBM, where you saw how much you can actually change the world by really using AI and giving healthcare to people that wouldn't get it otherwise, using the limited resources in the right way, and actually predicting future hotspots and things like that. So these are many, many reasons why I love using AI, but we also have to make sure that the dark side is managed correctly.
Thank you. Mr. Martino.
Good morning, everybody. Thank you for having me here. So I'm a 50-year entrepreneur. Started in technology in 1978, so before a lot of people here were even born, which is fortunate and unfortunate. Technology comes and goes, however, it definitely repeats, and everything we're seeing today revolves about everything we started all the way back in the 60s. AI, I've been involved in since 2012. It's very heavily entwined in our technology, in our company. I think that the ethical implementation of AI, including both data sovereignty and emotional sovereignty, is going to be very important. So we've been working very hard, I've been working very hard in establishing patents and technologies that will help guide the future in the use of AI. So this is my 7th company. I have 6 exits, 3 to public firms, so I think I know about how to get things into the marketplace for the betterment of mankind.
Amazing. Dr. Aerts.
Why I'm passionate about AI? Well, as a medical doctor, I really love AI because finally, after all these years, we will be able to understand what truly drives our health. This massive amount of data and the computational power we now have in our hands can help us decipher what drives health outcomes and what drives health inequities. And that is why I love AI, because this is something we were waiting for since a long, long time. We have been treating our patients perfectly with all of the best therapeutic scientific innovations we can imagine, but as we heard massively this morning already, many people don't even get access to it or don't get the treatment they deserve because it's not well diagnosed, or they simply don't have access. So AI can handle all of these different aspects, in fact.
Thank you, Dr. Aerts. And let's actually take that and lead into the first central question, which is the heart of this discussion. I think we've seen the headlines of AI, some predicting utopia, some predicting dystopia. The question is, the real story is unfolding right now and in this conversation. The question is, AI bridges divide. Will AI bridge divides in health or deepen those divides? Would love to hear your perspectives on how AI can be a force for equity. Maybe we could start with you, Doctor.
So the most important thing is actually that we do equity by design. So it cannot be an afterthought. It cannot be that we build a model and then afterwards go like, oh, okay, but now how do we fix it? The big problem is it's actually the cheapest thing to do is to build a model that works very well for the white male American from the East Coast or the West Coast. Because they are the main producer of data. That's the best data that we have available, and they are the most homogenistic group. And so if you build a machine learning algorithm, they're always looking for where's the most data. We have hardly any data of, I live in the Dubai, Emirati women over 65, or Saudi women in remote areas, and so on. And that's why it's really difficult actually to build AI models that are including them, because we struggle with getting the right information. We have always ignored women in healthcare. We heard it earlier, the risk of heart attack and the diagnosis of heart attack. And we see that with AI models going forward. So by really having the inclusive teams, making sure the team is diverse, you have women in the team who says, hold on, this doesn't work for people like me. Having the most diverse background, putting equity as a forethought, and finding a way to incentivize it, and saying, okay, it's not just about accuracy of and to be 99% accurate if you just look at white male, but actually saying how much do we close the diversity group, and having that as an incentive as well in the AI.
Thank you, Doctor. Mr. Martino, how would you take that?
Yeah, I agree, especially at the subgroups, and not being able to use averages is extremely important. So diversity of ethnicity for data gathering is probably one of the most important parts of the whole AI model from a modeling standpoint. But I think there's also some other issues that we need to think about. How do we fund it? So funding, especially for the South group, is Global South is very important. How do the islands nations get involved? How do we make sure that there's low enough cost for introduction of AI into the models from the standpoint of usability? And how is that data going to be gathered afterwards? So the total cost of ownership and discipline for interoperability between the different organizations is extremely important going forward. And without that inclusion of data across all the different lines, it's going to be very difficult. One, to make it ethically available, and two, to make it low cost enough for introduction into the world.
Thank you. Dr. Aerts.
Yes, I believe that AI is exactly the solution to understand what we can do to address health inequities. And that's why I'm such a supporter of it. So we can decipher what the underlying drivers of our health are, and then try new interventions to address those, or to target the interventions that we know that work to the populations with these kind of underlying determinants. Let me give you an example from here in New York City. We did our initiative AI for Healthy Cities is an initiative globally, and we run that in New York, in Singapore, in Helsinki, and in Basel in Switzerland, where we bring together the existing data from the health sector and the data from health influencing sectors, be it housing, transport, food, safety, you name it, all the determinants that also influence our health outcomes. And then now we can quantify which are the main drivers that influence cardiovascular outcome. So we can deliver the health authorities in the city, and we work hand in hand with the Department of Health and Mental Hygiene here and many other partners. We can deliver maps, if you may, per census tract, which is communities of 2,000-3,000 people in New York City, and pinpoint here the main driver is access to healthy food. There, the main driver is access to internet. For hypertension, for example, the main driver is a long commute time. And so you need to understand these underlying drivers to be able to do something about it, and then not continue with blanket approaches in a city, which is far too expensive. You can really allocate your resources to where they are needed most and where they can have the largest impact on the greatest number of people. So for me, AI is definitely a bridge to address health inequities, if you may. But I cannot agree more with my two co-panelists. You have to avoid that you create biases if the data sets you have in your hands are not representative of the entire populations. It's an issue. So you need, in initiatives like AI for Healthy Cities, we needed to complement the quantitative analytics with a qualitative survey, an ethnographic survey where you do focus groups, interviews with community players, community organizations, and experts to make sure you also know the lived experience, so that you know you don't miss invisible populations. And then combining the insights from both qualitative and quantitative analytics is a very powerful tool now, which we have now available for New York, Singapore, and Helsinki.
Thank you, Dr. Aerts. I think what you've heard here is also a lot about framing the stakes, the gaps, the opportunities. There's a lot of things that are going on, a lot of things that are happening at lightning fast speed. So as mentioning what Enrique and Stephen had framed in the beginning of the conversation today, to make sure that you hear, obviously you have three global leaders and innovators who are entrenched in this space and advancing this space forward, but many of you around the room are advancing this in your own right. So figuring out how we can work together to address some of the issues of diversity and tackle some of the opportunities and convert challenges into solutions especially knowing that where some of the biases are. So with this, let's build on that by talking about some of the things that are actually happening on the ground with some concrete examples. So if we can look at one promising innovation, so or what would you see as the most promising AI innovation, AI-driven innovation today in health, and why? Maybe that'll be some people may have heard of it. For the others, it'll be new education. Would love to go around the panel for that.
I think for me, I think a lot of people expect me to say large language models now, but I'd actually say that is a really good tool, but for me the most amazing thing is the understanding of the data, the building of connected ecosystem, and the breaking down of silos. Because with that, we can really see how much our food impacts our diseases. And we move from a reactive healthcare of somebody coming in when they're already sick to predictive healthcare of saying, oh, if you do this and this and this will lead to this and this and this. Or we see certain trends happening and saying, okay, you know what, we actually expect a hotspot here for the next pandemic. And so we can actually forecast what will probably happen. And that is much cheaper and a much better use of resources. And saying, okay, now let's interact and make sure the damage doesn't even happen.
Very interesting. Mr. Martino.
I like the comment that she made about silos. So in the healthcare today, we see a lot of specialists, and those specialists basically understand what goes on with one thing, one part of your body. I think moving from reactive to proactive is the way to go. I think that personal healthcare and the implementation of the newer technologies that are allowing you to look at interactions between different organs or different parts of your body for cause and effect is extremely important. I think it's the most important part. If you want to be predictive, you need to understand what the root causes are. And it's not waiting until you get into the hospital or your doctor or a clinic to get an x-ray. It's being able to have data available for them to analyze before you get there. And I think this is one of the most important areas. I also think that the current technologies that are pervasive out there from a PPG standpoint, the watches, the rings, they're all very interesting, but they don't really tell you very much. They're a reactive technology, and we need to flip that around. So it's extremely proactive, and that the data, through data sovereignty and being made available to doctors, is available for pre-analysis and review. So you're walking into a situation where people are actually looking at taking care of an issue ahead of time that's been diagnosed to help reduce the long-term effects. And I think the current technology wave that is happening out there will make what's gone on for the last 10 to 15 years basically blasé and replaceable.
That's very exciting. Dr. Aerts, what's your vision for what's the
I
idea?
would say I totally agree with both my colleagues here, and I would prefer also the predictive analytics when we can build the tools, the predictive tools, to understand what is going to be your risk in a few years from now. This is now totally feasible at individual level. For example, we can predict cardiovascular events as good as a clinical predictor with lots of biological samples without any clinical exam, without any biological sample, simply by using the social determinants that we have identified to be the main drivers of your cardiovascular outcomes. So these kind of tools are extremely handy for health systems where there's not enough health professionals, or where you want to have the patients or the people engage much more proactively in their own health. But also at population level, you can use the predictive analytics to simulate for the decision makers which interventions will have the largest impact and the lowest cost. So this is a tool that we have developed with our other main urban health initiative that we run in 40 cities in the world, where we bring the data in and the governments can use the existing evidence from global evidence and introduce their local data, 20% of their local data, to understand which intervention they should really invest in to have the largest impact. It's a tool that every government is asking us for, and that is the promise of AI. That is not a promise anymore, but it is already reality.
Very insightful, Doctor. So now I think you've heard some of the innovations, you've heard some of the big visions. I'd like to go a little bit deeper into each of the panelists' areas of focus. Maybe Ms. Martino, we can start with you about the topic of scaling innovation. So the idea of how can startups and innovators make sure that their AI tools just don't get stuck in pilots, and they actually have the opportunity to scale into systems that serve people at large.
That's a very interesting question, especially from the standpoint of personal healthcare. How do you take technology and get it widely dispersed, and what type of process do you do that with? So in our case, we're looking at introducing technologies with partners into user groups that it is usable immediately so that you can get larger scale distributions. I think having partnerships is extremely important, especially if you're looking to scale and gather a lot of data to be able to support your thesis and your approach to technology. The other is trying to be a thought leader and have people recognize what you're doing as a company as very leading edge and the next generation. I think next generation has to be looked at. Previous generation technology is not going to help you make the leapfrog. So in our case, it would be being a leader in AI technology and ethical use and boundaries built into the technologies. And we're going to support an open source foundation in some of that area so that technologies that we're working on, we can get other people involved in. Start a discussion at a much broader level for adoption of ethical implementation standards, as well as testing and stress testing. So getting it distributed to very large communities is the only way that you can get into the marketplace. And I think partnerships and joint ventures are a very, very strong way of doing that. Nobody can create everything. We currently have 3 joint ventures, and we're looking at 4 more joint ventures that we're working on. And I think that by working together, you get to scale quicker and you get to deploy quicker, thereby giving you what you need, data. Without the data, nothing else works. And just to go back to a point that you had mentioned, getting data around the world is extremely difficult. Outside of the developed world, basically 90% of the people never see a doctor, or when they do, that data is never gathered. We need to figure out how to get that data. And getting that data can also be a way of distribution of technology for large-scale studies. So I think it's extremely important that we look at that.
I quickly want to add on that 97% of the global compute power in data centers are in the global north. And so it is really, there is no data about the south. And it's nearly impossible to build AI for them. And having to produce the data and collecting the data, it makes it incredibly expensive as well.
Yeah, just one point. I was heavily involved after the earthquake in Haiti, and just trying to get healthcare for children down there. And these are people who had never seen a doctor before. And what do you do with the data? So we developed a system where they could personally carry their data with them in a bracelet. And if they showed up at a hospital or a clinic, the data was there. And that's the start of personalized data that I was involved in. But it's so very important, especially in the global south, where very little data is gathered.
You talk about data gathering. Dr. Aerts, you've worked across the globe at also a very local level in many different communities. In all of your health initiatives, you work hand in hand with local authorities, communities, and partners in different sectors and different disciplines. The question is, how and when do you realize the importance of data and technology for catalyzing healthier populations?
Yeah, I think I fully agree with you, John, that the partnerships is key to success. In global health, all the issues are far too large to address as one player alone. We have to do this together. And for example, we just announced this week our partnership with Bayer. Bayer Consumer Health is going to support further expansion of our initiative Cardio for Cities, which brings cardiovascular health through entire city populations already in 40 cities around the world, and will now expand to 3 more cities in the US here, thanks to this partnership. So you combine resources to multiply impact. This is our way of scaling our innovative approaches and successful models. And I cannot agree more that it's a shared glory, then afterwards it's so much more fun than glory on your own. But when I realized that data is essential is by starting to implement what we know needs to be done. For cardiovascular disease, take this as an example, it's still the #1 reason of mortality in the world. And we have made tremendous scientific progress in cardiovascular care over the past decennia. So why don't we get that implemented? We just don't get done what we know needs to be done. And we developed a very simple approach, Cardio for Cities, that works in all kinds of settings, low income or high income, with crystal clear focus on earlier detection and adequate management of cardiovascular risk as soon as possible, and based on a data-driven approach and intersectoral partnerships. You cannot do it alone. It has to include the sectors that influence cardiovascular health. But the data is what makes the shift from doing just usual care to being very rapidly successful. If you show data to the decision makers in the city every month or quarter to demonstrate how many people they should have in the system with a certain cardiovascular risk, let's take hypertension, and how many they actually have, and then compare how many of those they have under control. When you show that data and revise that regularly, the authorities are really compelled to do better. And this, in 1 year of implementation in a city like Sao Paulo, for example, 16 million people, we tripled blood pressure control rates, and that translated in a reduction of 12% of strokes and 13% of heart attacks in 1 year of implementation. This mindset shift is what counts. And this approach is now what we have been implementing in 40 more cities. We want to reach 150 million people by 2027 with these partners like Bayer and like other partners we already work with in many, many countries. It's that it will bring the success, the data-driven approach, the local ownership, and the partnerships.
And I would like actually to say on that, it's really important that we get the governments involved into establishing data sharing frameworks, that we have trusted data that we can share. And I was recently doing some research in Germany on brain scans, and it was impossible to get the data from another hospital because they wouldn't share it. Because why should they? Why should they support somebody else's research when they're not on the paper? Or when they're not first on the paper? It's very important which position you're in. So in the end, our data set was very, very limited, and it could have been so much better by including more hospitals and actually working together and saying, this is how we have a trusted and privacy-protecting sharing framework, that this data is available for everybody and not just for every single hospital differently.
So I think you've been hearing AI itself is a tool, but it's a tool that can be used as a force for good if done right, if taken some of these things into consideration. I think as we round out, because I think we're almost at time, would love to ask each of you for kind of a rapid fire question as you think about how to engage the audience here and those who will be listening. How would you encourage this room to act? What's the single biggest or most important thing that could happen in the next 5 years to truly to ensure AI truly advances health equity? Please.
Sure. I think inclusion of the public, private, and government initiatives need to be fully exploited. And to do that, distribution of leading edge technology with embedded AI would be a start. That's one of the reasons why I'm here. We have some technology we're not looking to make any money on, but we'd love to have babies have their hearing tested everywhere in the world for free. And we've made a device that could be distributed through the network, costs less than $100 to make. It works 95.7% as well as an $8,000 device that's used in developed countries to test babies' hearing. 6% of all children under 11 have severe hearing problems by the time they're 11. It's something that we need to look at. So starting to gather health data from infancy on normally isn't done anywhere. Even children don't go. So I think these types of initiatives in getting technology distributed around the world that has AI that starts modeling at younger ages is extremely important. And there's a lot of technology out there that we can get distributed to do that, working in partnership.
Thank you. Dr. Eva-Marie?
Yeah, I think what I said earlier, the governments really need to make sure there are rules and regulations in place to share. And the private sector understands that there is a solid use case for building more diversity, for building more equity, and for making sure that the AI solutions that we're building are not just for a few, but it's actually a sharing framework, and the data should be accessible for everyone.
Thank you. Dr. Aerts, please close us out for the next 5 years.
Well, what I would like to see, maybe not in 5 years, but for the next generation, that we all work together and use the data we can have, even if it's not perfect, but converge that AI technology with scientific technology that is now available, and we would be able to eliminate heart attacks in the next generation. That's what I want to do, thanks to the power of data and AI.
Very inspiring. I think we're just about time. I think the key message also is it's not just technology, it's about governance, scale, equity, and ultimately the courage to act, which I think hopefully you can all leave this conversation by our esteemed speakers inspired to do so. Dr. Eva-Marie, Mr. Martino, Dr. Aerts, thank you for joining us. Thank you for sharing your perspectives with us today.
Thank you for having me.
Thank you.